Uh, Thank you, Shine, and all the other pulmonary hypertension experts for the invitation. Let me be honest in telling you, I was not told that it is in the pulmonary hypertension session. They told me just to talk about AFR and atrial septostomy. So, yeah, couple of slides may go off track, but I will try to retain my straps back. Atrial hypertension is getting relieved by some form of creation of atrial septal communication. The most common indication for an atrial decompression in the right atrium will be a WHO type 1 pulmonary hypertension, which is the largest patient load, or an operated congenital heart disease with pulmonary hypertension. Of course, this can also be done in a restrictive PFO in critical RVOT obstruction or RV hypoplasia, critical PFO in a tricuspid atresia, TAPVC, as an extension of failing fontan, left atrial hypertension with heart failure with preserved ejection fraction or some forms of cardiomyopathy, or univentricular heart with congenital mitral stenosis or HLHS. Whenever we are doing an ECMO in a patient who is having severe left ventricular failure, if they are having associated mitral regurgitation, you don't relieve the pulmonary edema unless you create a septostomy. And one new added entity is post RF ablation for atrial fibrillation. This atrium becomes very stiff and these patients get recurrent flash pulmonary edema. The traditional old methods of septostomy had been balloon atrial septostomy or blade atrial septostomy. But if you look at what are the different ways to create a septostomy, all the methods like balloon septostomy, blade septostomy, static balloon dilatation, broken burrow septostomy, everything is rather uncontrolled except atrial septal stenting, because it gives a predictable orifice diameter titrated according to the need, and it will work even in a very thick septum. The longevity of the palliation is maximum. It doesn't close spontaneously, and it is the best reliable strategy whenever whenever we need the perforation to be patent. Now, some of the examples: a 1-year-old child with a congenital severe mitral stenosis who is a single ventricle where there is an uncertain pulmonary vascular resistance. So this is a atrial septal stenting that is being performed. But in a hypoplastic left heart syndrome, in a day 8 baby with a very tiny restrictive PFO with a saturation of just around 40%, the patient is too unstable for an RWOD, and so you do an atrial septal stenting. Now, can you control the position of the stent? We can do something called as a partial unsheathing. So 50% of the stent, you open it out, pull back the sheath, and then deploy the remaining part of the stent so that you are able to position the stent exactly in the midline of the septum. Of course, there is another method, what is called as a diabolo stent. Basically, you take a balloon, put in a coronary guide wire, create a stitch over it, and now after that, recollapse that same balloon, fix the stent on the top of it, and then go ahead and deploy it. So this is the coronary wire that is running in. So these are all methods in which you can create a safer septal stenting, of course, with an echo guidance or with a 3D echo guidance. The basic rules of these methods will be: measure the mid right atrium to mid left atrium. That will be the stent length. The stent diameter will be dependent on the age of the patient and approximately how much of cardiac output you want to cross over. Let's assume the situation of tricuspid atresia, mitral atresia, or TAPVC and all. You want 100% of the cardiac output to cross over. So that means that stent has to be very large and non-restrictive. If it is something like a mitral stenosis, where congenital mitral stenosis in a univentricular heart, where you want the left atrium to be a little bit decompressed, then it can be even up to around 50% of the cardiac output. If it crosses over, that is good enough. But in a patient who is having, for example, idiopathic pulmonary hypertension, what you need is only around 10 to 20%. And this has already been worked up. And around 8 millimeter fenestration in the atrial septum in an adolescent and an adult will deliver 10 to 20% of cardiac output on the contralateral side. So once you fix on the diameters, then it becomes easier to implement. While the atrial septal stent needs a lot of playing around with the gadgets, dedicated devices are Corby IASD device, V-Wave, and Occlutech AFR, which transiently was available in our country, and we did a lot of patients, but then the company has withdrawn. What is needed for an atrial fenestration? That we need a very predictable fenestration orifice. We need to be exactly the same diameter what we want to achieve. And it should be predetermined for the age of the patient. Depending on if the child is too young, I want it very small. I want it just about 6 millimeter. If the patient is quite grown up, large body surface area, I need it up to around 10 10 millimeter. It should be predetermined depending on the atrial pressures. Let's assume that my right atrial pressure in an idiopathic pulmonary hypertension is 24 millimeters of mercury. Actually, it is set to be a contraindication. More than 20 millimeters right atrial pressure is a contraindication. However, there will be a sick patient who is having, say, 24 millimeters again, who is quite moribund. Even if you create a small decompression, that is going to work. So in those patients, you may be going for a very small AFR. Whereas if the patient's RA pressure is just about 13, 14, then you can go for a larger sized AFR. So, and the ease of the procedure, it should not be very complex gadget. It should be just take it, deploy and come out. No fabric to avoid any thrombosis. Whenever there is any fabric, for example, a fenestrated amplatzer device, so no fabric to avoid thrombosis, the patency has to be retained. It should suit all the septal thickness, irrespective of whether it is a pericardial patch, a Gore-Tex patch, whatever be the atrial septum, it should be accommodating, and it should be feasible to close at a later age. So this is an atrial AFR in a patient with idiopathic pulmonary hypertension. This is the contrast echo that has been done through the sheath after the procedure. You can appreciate that the RV is literally non-contractile. RA is quite tense, and a good amount of contrast is now crossing over from the right to left. This is a contrast that is spilled over through the sheath, and you can see the amount of contrast that is spilling over. This is at the end of around 4 years. Still the patency is retained. This patency is never will close. As long as the hole is around 6 millimeter in a young child and 8 to 10 millimeter in an adult, it will never close. It just endothelializes and it never closes. So we published our data in the pulmonary circulation in 2021, a total of 39 patients. I'll show the brief data. You see that the patients had a reveal score of more than 12 in about 6 of them. Roughly about 1/6 of the patients had a reveal score of more than 12. What does this mean? A reveal score of more than 12 gives a predicted 1-year survival of about 40%. And we followed them for about 27 months median follow. So roughly, if you don't go by hardcore statistics and all, at the end of 27 months, I should have a little close to about 70% of the patients dying. So here we had about 50% of the patient dead. Now come to the reveal score of 6 to 12, which is the majority. A large majority of them were in the reveal score of 6 to 10. The predicted 1-year survival is around 70%. These are actually the reveal scores. And this is the 12-month, 24-month, 36-month, 48-month mortalities by the reveal registry. And the predicted predicted survival at the end of 1 year is close to 70%. That means 30% of them will be dead. But this, at the end of 27 months, we had everybody surviving. Reveal score of less than 6, that was a minority. The predicted 1-year survival was around 93%, and all the 4 of our patients survived. So what does it actually mean? If the patient is quite moribund with quite completely abnormal hemodynamics, and they are far advanced in their status, even if you do an atrial septostomy, you will not be able to completely treat them. However, a small proportion of them may tend to survive. But in the moderate group, where it's around 6 to 12 reveal score, where the predicted 1-year survival is as low as only 70%, you are able to get them living without a mortality for a longer period of time. Now we have this study was closed at around 2020, and we have another 2 more years of follow-up. While we had a total of 3 patients dying up to 2020, we had 2 more additions in the next 2 full years. So it's total of 5 out of the 39 who have died. All the remaining are still surviving. It's very, very satisfying to see them surviving despite their need for 2 or 3 pulmonary vasodilator therapy. Now, this is the cardiac index that improved in all of them by quick oximetry at the end of 3 months. This is the systemic oxygen transport calculated by the cardiac index into the oxygen saturations. And so the question that is often asked is, what is the size for a given patient? If the patient is less than 12 years, that means a child, always it's a 6 mm AFR. We never use a 4 mm AFR because 4 mm AFR is too small, and 4 mm AFR tends to close off very quickly, whereas 6 mm AFR tends to retain its patency. If it is more than 12 years, we looked at the RA pressures. If the RA pressure is more than 12, that means they are manifest heart failure. Put a 8 mm AFR. If the RA pressure is less than 12, either with diuretics or without diuretics, the patient's RA pressure is less than 12, choose a 10 mm AFR, because 10 mm AFR will be needed to deliver close to about 10 to 20% cardiac output to the other side. Now, as an extension, if you see, this is a congenital heart disease with a right heart hypoplasia. with severely elevated RA pressure. The RA pressure is as high as 20 millimeters in a 22-year-old. You just keep watching. The contrast that was injected in the superior vena cava just stays in the right atrium for another 10 minutes. And this is the hypoplastic right ventricle with a hypoplastic diminutive tricuspid valve. There are not too many options that are available. We can of course do a Glenn shunt to decompress, but the right atrial pressure was quite a lot. So what we did was we did a combination. We did the right Glenn shunt, and we did a tricuspid valve as best as possible, a balloon dilatation in order to decompress. And we wanted to put in a controlled fenestration on the atrial septum. So this is an atrial flow regulator. With this, the atrial pressure got down to somewhere close to 8 millimeters. Dilatation that we did parallelly kept on improving over a period of time. The tricuspid valves kept on stretching, and now the patient is actually saturating completely normal 98% at the end of about 4 years of age. Some of the Fontan failures also can be treated by this fenestrated device. AFR towards the end in left atrial hypertension, it may be used in heart failure with preserved ejection fraction. Some cardiomyopathy, restrictive cardiomyopathy with recurrent flash pulmonary edema, hypertrophic cardiomyopathy with flash pulmonary edema, we have used it. Stiff left atrial septum syndrome, as I told, in post-RF patients, we have used it, and in congenital mitral stenosis with univentricular heart also we have done it. Whenever these patients, this is an example of a cardiomyopathy post-ICD, hypertrophic cardiomyopathy with recurrent pulmonary edema, where after an ICD we put in an AFR, and this is a coronary artery bypass graft. I don't know whether you are able to see, there are multiple clips running down. A patient with a small LV, heart failure, preserved ejection fraction, recurrent. So to summarize, there are different methods that are available today to create an atrial septostomy. Now, as the tip, I will say, whenever you are doing a septal puncture in any of these patients, it's better to keep a woven-4 wire through it and advance it so that you prevent a left atrial roof injury. The stent length, if you are using an atrial septal stent, it has to be between mid-RA to mid-LA by echocardiography. The stent, you have to decide whether it is, what is the age of the patient and what is the percentage of cardiac output that you want to deliver. For example, if it's a hypoplastic left heart syndrome, we want the entire pulmonary veins to come inside. So the stent will be as large as 12 millimeter or so. If it is a congenital mitral stenosis, it's some amount of antegrade flow, even an 8 millimeter is enough. But if it is a smaller child with idiopathic pulmonary hypertension, probably a 6 millimeters is enough. So AFR size is based on atrial pressure and the age of the patient. Echo guidance is crucial. Stent or AFR, both will give very predictable, reliable, durable opening. Atrial decompression relieves the symptoms, not only in but also in heart failure with preserved ejection fraction. Thank you for your attention.